All right, well, welcome everyone. Thank you for joining Amethyst at Penn's November 2024 seminar. We're proud to offer this content through our Amethyst at Penn Hub, which stands for Achieving Maternal Equity and Transforming Health Through Implementation Science and Training. Funding for this hub comes from the NIH's Improve initiative, which aims to reduce maternal mortality, improve pregnancy, perinatal, and postpartum care, and to address the factors that have led to severe disparities in outcomes for marginalized groups. As a reminder, we will be recording this discussion and it will be available on our YouTube channel for review after the session. Please feel free to put any questions in the chat, and we will also have time for additional questions at the end. This month, we are featuring a panel on increasing rigor and best practices for implementation science research studies. Our panelists are Drs. Katharine Rendle, Amanda Bettencourt, and Shimrit Keddem, and our discussion will be moderated by Dr. Meghan Lane-Fall. Meghan, I will turn it over to you.
Casey, thanks so much. And do we have folks pinned yet? I just want to make sure the view is good. And for participants, you can always put it on, multi-speaker or speaker view if you want to make us bigger. But welcome, as Casey mentioned. My name is Meghan Lane-Fall. I'm the co-PI of the AMETHIST Penn initiative, which I lead with Rebecca Ham. I'm an implementation scientist, and I get to lead the Implementation Science Center here. And it's my great pleasure to moderate this discussion. So we don't have slides. This is going to be a discussion about best practices in implementation research, sort of hard-fought lessons learned from the field. I'm going to ask each of our panelists to introduce themselves because I want them to tell you a little bit about their experience leading implementation research in the interest of reflexivity. I know them all, they're amazing people, but I want you to hear in their own words what they bring to the table, what their roles are, and then once they introduce themselves, we'll launch into more discussion. If you have questions, please put them in the chat, and there will be plenty of opportunity for you to ask questions as well. So let's start with Dr. Bettencourt, and I'll use the title doctor to start, and then I'll just use first names, but Dr. Bettencourt, go for it.
Thank you, Dr. Lane-Fall. Hi, everyone. Amanda Bettencourt. I'm an assistant professor in the nursing school here at Penn, and I'm a clinical nurse specialist, advanced practice nurse. So I am both a person who has a lot of experience leading practical implementation teams in the healthcare setting in my advanced practice role. And then also from a research perspective, I run a hybrid type 2 trial about telemedicine for crisis planning and burn care, which is pretty interesting. So I've got a large 24 sites in that research study that I manage. And then I'm also a co-investigator that runs the implementation science parts of a couple of other studies, mostly in the pediatric realm, pediatric ICU care, use of midline catheters, overuse of vancomycin, a bunch of different clinical interventions. So I have lots of experience on different teams, excited to share more with all of you in the panel today. Thanks so much.
Thanks, Amanda. Dr. Keddem.
Hello, everyone. My name is Shimrit Keddem, and I have two appointments. I am an assistant professor in Department of Family Medicine and Community Health at the University of Pennsylvania, but I'm also affiliated with the U.S. Veterans Health Administration, where I'm affiliated with a local center, actually local to Philly and Pittsburgh, called the CHIRP, the Center for Health Equity Research and Promotion, where I am an investigator and also a core director of our qualitative methods core. And I would say what has shaped a lot of my work around implementation science is my expertise in qualitative methods. I have a couple decades working a lot in qualitative methodology and all of that. And you'll probably notice that in some of my responses to some of the discussion points today. So I've been at the VA for about 10 years. And the VA is really a unique environment. We have one of the largest integrated healthcare systems, probably in the world. And we do a ton of implementation work across the country. And so I've been involved in several national evaluations and regional evaluations. And one of the big projects that we did a while back was a project to improve patient-centered care in the region, where we rolled out, we created a toolkit first, and then we rolled it out, disseminated it, and then evaluated the outcomes for patient engagement.
Thank
Pleasure
you so
to
much.
be here.
Shimrit and Dr. Rendle.
Hello, everyone. My name is Kate Rendle. I am an associate professor in Penn in family medicine with Shimrit. And I also have a secondary role in our division of Epi and also a role in our cancer center at Penn. I am trained as an anthropologist and epidemiologist. I came to implementation science through cancer. So most of my work is in cancer. It spans from primary prevention all the way to survivorship, and I do multiple types of cancer. I work in the United States, and I also work in Botswana and Southern Africa. And I have several large pragmatic trials right now in implementation science, one in de-implementation, one in cervical cancer treatment in Botswana, and then one in lung cancer screening in the States. And I sort of bring together the two views of anthropological sort of context is very much aligned, of course, with implementation science, and then trying to figure out what to do with all that context and control for it from an epidemiological perspective, and bring those two perspectives into my work. Thank you for having me.
Kate, thanks so much. So as we launch into our moderated panel, I want to start off thinking about the research team and the sort of nuts and bolts of managing an implementation research team. Let's talk about field notes. So there are lots of insights that the team has in the course of doing implementation research. Those insights can come from team meetings, it can come from interactions with participants, it can come from talking to the IRB. So how do you manage that? How do you catalog the notes, the insights that people have? And then what do you do with it? And whoever feels called to speak, please go ahead.
I guess I don't know. I guess I feel called to speak. Okay. I find that I am more formalized about keeping and cataloging these now than I was when I first started doing implementation research. And I think, to me, I'm really interested in how clinicians change practice in teams in the clinical environment. And there's so much reading between the lines that I feel like I do when I watch these teams learn about doing a new thing. And the things that they won't say out loud that I'm myself or other folks in our team are maybe observing have been some of the most valuable field notes. So when I'm talking to clinicians about, are you going to be willing to change this thing? I'm working on an ECMO project. And I say something like, thinking about changing it, would you be willing to do it? And they all say, oh yeah, sure, of course. But you know that they really don't want to. Those are the types of things I capture in a field note, like when they're looking at each other in a meeting and you can tell that they think this is the dumbest idea ever or whatever. So I kind of put down those tacit feelings that I'm observing more and more into field notes, and then keep them. And then when something is being planned, oh, sorry. Yes, thank you, Megan. It's about a heart-lung machine for kids. But and so it's really become super valuable, both when things don't work the way they should. I sometimes can explain that by things that our team felt were unsaid by participants in our study. But then also when it comes time to choose strategies or to decide what's going to be in a toolkit for a project, I find I go to those and I make sure that I can try to cover some of those observations our team had that maybe were different from what the people actually said out loud when we asked them about different things. And that's been really valuable in a couple of different projects. So I think it's always good to like capture those feelings if you can, and everybody's perspective is different, store them together, and then be critically reviewing them before you make important decisions, just in case there's something there that could help inform the study.
That's great. And just to make it like optimally usable for folks, if we can drill down even a little bit more, where are you storing it? Like, is it in a Word doc? Is it in a shared drive? Like, where are you putting it?
Yeah, no, that's really important. So there's no template for field notes. It's just like people kind of writing what they think. We do have a shared, like a Penn box drive that's secure that our team members can put them in there. And that's where they're stored and everyone can see them. One of the things that's really important for our work with clinicians is that we protect the privacy of the subjects when they may work with each other. So the standard for saving those in the box is that there should be no identifying information about the people. It's never like if I'm in a meeting with you, Megan, and you roll your eyes, I wouldn't type Dr. Lane-Fall rolled her eyes when I said we were going to change the ECMO circuit, but I might say like a physician in the room was concerned or whatever. So those are the standards, but yeah, we just type them on Word documents, stick them in the box, and it's free form, whatever people want to put in there with no identifying information.
That's brilliant. Thank you. Kate, I think you had some thoughts.
Yeah, I was actually looking to see if my field note books were behind me in my bookshelf. So it's a funny thing because from an anthropological perspective, this is our only method that I learned as a graduate student. Like anthropology is everything else is like much more loosey-goosey and there was no research methods, right? And the only thing we learned how to do was write field notes. And so I actually had to do some unlearning. Because I still think that I'll sort of walk through. But the first question I think about writing field notes is what are you going to do with them? And why are you collecting them? Because if you are collecting them as evidence, as a document, as something you will analyze, there is some more formulaic things you might want to do. And you may want to use an observation template, for example, or protocol, right? So that you are capturing things in a consistent way. However, you also often, so like, I don't know if anyone has sort of the history of anthropology, Malinowski was like one of the first ethnographers, and his ex-wife sold his diary that he kept when he was in the field. And in that diary was all of the things that Amanda was talking about, some bad things as well, but we'll just sort of gloss over those. But the feelings, right? When you're immersed in situ in a place, right, of that's new and you're an outsider and you're not really wanted, right? They're there and you're sort of, but maybe they're okay with you having there, but are they acting differently? You as a person are going to have feelings. And so it's actually nice to be able to have a place to put those, right? Your own sort of like, this was really awful. I was in the clinic and I saw this thing happen and I like need to get it out of my body. Then you can also have those sort of formalized steps. So often a field note that you would produce in an ethnography example, you have all your messiness and then you write it up as if it was all like clean. And then that's what you produce in your book. So if you are going to use it as evidence, I think you should think about more formulaic, particularly across teams, right? Like there's certain things you want to do and observe to be able to analyze it with some validity across the sections. But I think that if it's for something other than evidence, for example, it can be used for a lot of things. Sometimes it's just tracking changes, right? Which we'll talk about. Sometimes it's protocol deviations. That's one way we actually do keep track of some of our like field notes, right? Is when it goes into if we have a trial that's something, this isn't like a safety concern like you might have a therapeutic trial, but like somebody was delivered the wrong strategy, right? Like it's actually a nice way to track some of those as well. So when you go to analyze your data, right, this is all context. And really that's what field notes are about, is context of doing the work, context of doing the implementation, and then context of all the people involved in the implementation. So I think really just the first question is what is your purpose? And then where, depending on that, is how formulaic or not, and how shared or not. Just don't give it to your ex-wife if you're nasty when you die. You might want to burn that. And then whether you share it, on one document or, some people, there are all sorts of ways you can share it. Even those like Miro boards people have used. I loathe Miro board. However, some people really like it. So whatever works, I think.
I really appreciate that. And I will say, I also appreciate that you called out whether you want to use these for evidence. And I was thinking about that as Amanda was talking, if this does actually inform a decision that you make, how do you make that transparent in reporting? And what how do you format the information?
Yeah.
I see.
Yeah.
Nelson has a comment or a question.
Yes, and thank you. I agree with Kate. I mean, field notes are extremely important, at least from my perspective. But I have to make a confession, and I hope this doesn't leave the United States of America, is that I have a terrible handwriting. I don't know if you remember something that was called tachygraphy, that it was a system to collect notes pretty fast and things like that. Well, my handwriting looks like tachygraphy. And I am the only person that can understand that. So what I do is I always have a combination of an iPad, with this pen that I can make the notes just by hand. And then, of course, I always have to ask for permission to record the session and use the AI tool so I can make the transcription of the recording. And in that case, what I do is I make all the edits and I share my notes with everybody that was in the meeting. And I do it fundamentally because every meeting is important, and you never know when a very fundamental piece of information will pop up, and you don't want to lose that. So for the process, that's what I do. and fundamentally because it's a good method to follow. And the other part, I mean, from the legal perspective, depending on the meeting, it might be, kind of an evidence type of notes. Then I go an extra level of careful when transcribing those notes and putting the notes to the notes so that people will understand what's happening. But if it's just kind of a technical meeting, opinions about some procedure or whatever, then I kept them as a source for additional information on the process. So, but I think every meeting needs to have good notes. I mean, at least for the implementation purpose.
That's wonderful. Thank you, Nelson.
And I appreciate that you have actually, I mean, this is where I keep my field notes, and I'm the only one who also can read my handwriting. I don't have a formal system, just terrible, but that is a very good practice after, if you're doing a handwritten or whatever, is to have sort of a formal step. It also lets you digest it too. Again, back to sort of like if there was something that came up that you need to work through. And I think the other thing that's really important, of course, is that it's not just what people are saying or what they're doing, right? The actual clinical context or community context, wherever you may be doing your implementation, can be really key points. So back to like your question, Megan, we had a study long ago that we couldn't figure out why people were waiting time differently. And we sat in the clinic for a couple days, and we realized that there were no magazines in any other language besides English. So if you're sitting in a waiting room and there's nothing to keep you, distracted if you don't speak English, your perception of time is different. And so we use that as evidence, right? We observed, field notice observed this, and this could be a potential driver of these differences. So I think as long as you're transparent and that you used it and how you used it, and you had some sort of formal way in which you tracked it, then I think it's perfectly reasonable. But I am biased as an anthropologist, so some may disagree.
And Nelson's comment reminds me, there are a lot of you on the Zoom call that have experience. So if you have it and you want to share it, please share it. We're not pretending that we know things that you don't know. We just want to generate a discussion. Shimrit, is there anything else you want to add to this?
Yeah. So I am not an anthropologist, but I was trained by an anthropologist for many years. And so I learned the same thing about field notes. You do the jottings first because, in the field, you may not have access to a computer. And anyways, you're just jotting things down as quickly as you can. And then you go back and you sit down in your office or whatever, and you actually type up your notes into a thick description. And I remember one time we did a site visit at the VA, like in California or something, and I was coming back on the plane, like frantically writing my field notes, and the woman sitting next to me on the plane was like, "Are you a journalist?" Because I had these like notes. So it's kind of like similar, you know what I mean? I had these written notes and then I was typing things. The other thing I wanted to add is, like, while I was trained by an anthropologist and, to get that thick description and really look at everything, I'm also a health services researcher with these very like sort of specific focused goals. And so in large teams where we have a lot of people, it's actually really helpful to have standardized things and, have templates. And like, because if somebody is sitting in a waiting room, our focus for our study, for example, for the patient engagement study, was patient engagement. And so if I send somebody out into the field to sit in a waiting room, I want them to know what to observe, what to focus on, right? Because in a waiting room, there's so many things, right? And so we developed some pretty detailed sort of templates to help people kind of focus their observation specifically on the topic that we were interested in. And then in implementation science too, we have all these frameworks and theories. You may want to build that into a template, right? Like you may want to build the constructs of your framework straight into a template at the observation stage, because that's your data collection stage. And we take those field notes and we put them usually on my teams into qualitative data analysis software, and we analyze them alongside our interviews and whatever other qualitative data we have using the code book that we develop, that kind of thing.
That's brilliant. Thank you. And I love the idea of, if you're going to use something structured, thinking about a framework from implementation science. I especially think about some of the determinant frameworks like CFIR, the Consolidated Framework for Implementation Research, or the TICD checklist, a Tailored Implementation for Chronic Diseases checklist. And you could imagine setting up a field notes template with the domains. Like, I wouldn't put the constructs in there, but maybe just the domains, just to give the observer something to focus on, because there is so much to see. So listening to all three of you, one thing that comes up for me is that the research team themselves become participants in a way, because the observations are really important. And I don't have an answer for this. This is really just a question. What are the ethical implications of the research team being participants? Do you need to consent them? Like, what things are you allowed to do? Can you interview your research team as part of the work and they say no? Like, how do you think about the ethics of the research team itself being part of the work?
I know Amanda has dealt with this very intricately, but this is something that comes up more. I mean, it always has come up, but it is this, in particular, in the global context, but it's not unique to the global context. We work in Botswana. There's one clinic, right? So we want to have partnerships. There's one cancer clinic where people can get cervical cancer treatment in the country. So we want to partner with our clinicians, but of course we also want to understand. I mean, think about clinical implementation. Key constituent is your clinician. So we have been when we had to choose, like if someone said, I really want to be involved, or I want to be a partner in this study, but I don't feel comfortable being interviewed, we always sort of put premise on the partnership. It does limit some of our data collection, but of course there would be some probably bias, right? That people always have bias. There's always bias, but what level of bias? But what we have done sometimes is just use it from sort of a context, right? You like write that description part of your implementation, your interpretation of the data. So even if they can't be interviewed because they're involved in the study, and ourself as well, right? Like it could be you yourself. You are influencing the interpretation of your findings. And of course, the operationalization of the actual strategies by being part of it. So I feel like you still get the benefit, but you can be actually a research participant and a partnership as well. You just have to be explicit about it.
Yeah, I would say that that's usually how we approach it as well. Kind of like, I think the having a research partner is so valuable that when a person, if I have to choose either or, be a participant or be a research partner, I'm always, if that's the right person, I want the research partnership first, and then we can find some other participants. So I try to think about it that way. But we have had folks that are both. And then, we do things like, for example, 2 hours ago, my team was doing some implementation mapping where we're looking at data, and a person on my team also was interviewed, and some of their data is in there. And we're making group investigator decisions about what are the right strategies and stuff for this group. And it's very clear that this person was hanging on the thing that they also had said when they were a participant. And so I think one of the ethical imperatives is to make sure everybody knows. Everybody who's on the investigative team knows if a person who's on the investigative team has also contributed, their data or when interviewed or whatever, so we can call each other out on those biases. And that's actually what happened in our meeting, which is great. From the IRB perspective, when a person is both, or at least the studies I've been involved in, because there's separate consent for being a participant rather than a research partner, we've just sort of said if somebody wants to be both, they would separately consent to, they would be on our team this way, and they would be a participant in whatever they wanted to on their own in the other way, and that those kind of are conceptually different consents. And so that's been okay with at least the handful of IRBs I've dealt with this. But I think it's more about being very transparent among the team, and also when we report the results, if that's the case, and just being really clear about how people were involved, and that nobody's agenda, it's really about making sure no one's agenda gets pushed higher than anyone else's based on their role, I think, and we've tried to manage it, but it's tough. But I think we can make it work with the right kind of structure and a lot of transparency.
Yeah, the consent issue is interesting, and it seems like it might be prudent to err on the side of being more conservative and maybe consenting people just to cover your bases. There's not really an expectation of anonymity, right? If you're part of the team, so that risk benefit ratio, I guess, is a little different for those folks. Okay, let's move on to talking about communication within our teams. So our teams in implementation research can sometimes be very big. People at different levels with different roles. I'm running a study right now that has 3 different sub-teams and multiple members of those sub-teams. And so we have to be really thoughtful about how we communicate across those sub-teams and making sure that everyone's on the same page. So can you all talk about how you approach communicating within your team, and if you have any tips or things that you definitely recommend that people not do when it comes to communicating?
I can share a strategy that I use. I've actually talked to Kate about this. So, I mean, I don't love meetings, and to make my meetings more efficient, I try to use, and I kind of hate agendas, but I use, or meeting notes. I use like a living agenda, I call it. I made it up. It's usually in a Word doc that we save a new one every time we meet. So if we meet a weekly or bi-weekly basis. And what's in it is kind of like, it's a shared document where we keep track of the progress of our project, including kind of like a little bit of past, present, and future. And it looks like kind of like an outline, and everybody in the team gets assigned different tasks, and they're kind of like the masters of those tasks. And they would come back to the document, and even in between meeting, and update the document, especially if it's like we're about to meet, just to update it to let everybody know what's been done on that task. And then during the meeting, we run the list. That's what I call it. We run the list. So we go through ABC, like, how's this going? And everybody kind of reports on what they've done. And a lot of times we do have like these subgroups of like, maybe one of the items is like 3 people on the team had some sort of other meeting and made some progress on something, and they will report back during our team meeting because that's on the list. And that kind of stays like I said, like a living agenda that evolves over time, and we save versions of it. And it's accessible in a shared space where everybody can access it. And so our meetings are strictly running the list. And if we need a meeting for some other task, we usually do that separately, right? Like if we need to like develop a code book or whatever, that's done in a separate meeting.
Yeah, our team does something similar where we have standing meetings. It used to be every week. Now it's every other week. It's half an hour. There's a standing agenda and we run the list, and each team reports out. And then there's a couple of other standard items that we cover. Kate or Amanda, any thoughts about maintaining good communication within the team?
Yeah, I mean, I think that there's, it's funny, I use it similar as well. And I started it back 15 years ago now. I think I have an agenda that it just runs and it updates on Box. So that's one thing. You don't even have to save a new version, right? So there are new technology tools that can help with these, but that's for my local team. For the implementation team. So this is when you're thinking about team, like think about your closeness with the team, your established communication, right? Like my team and I have been working together for 5+ years, right? We have a shorthand. We use Teams chat actually. So like immediate things, right? Like what we used to just jump over and talk to each other. We use that. We have this agenda we go through once a week. But for our larger implementation teams, we do a different strategies. We have a standing meeting on the books, in part because scheduling is so hard. It's much easier to cancel something. And most people are not irritated when you cancel a meeting, as long as you sort of tell them right in advance. But we also use sort of things, point people. So having like delegation of communication, I think is really important. Like PIs are often not the one that you want to go to, right? You want to have a really robust team, project managers, whoever it is. But either way, knowing who's the responsible person to make sure they gather the information, that's really important. And then you can use sort of different strategies for different groups. So I have a running WhatsApp chat with my 2 people that are actually sort of delivering the strategies in Botswana. And we just chat on WhatsApp because that's what works for them. And so every Monday I look on WhatsApp and we go through the things. So I think it is being flexible, but having some sort of structure and delegation expectation for who's doing what. Relying on one person, particularly if it's the PI or a study lead, you either will burn yourself out or you will get so exhausted and forget things that it will lead to disaster. So delegation, structure, and then be flexible on what platform works for people.
Those sound great. And I can absolutely endorse the set up a standing meeting, because it's so hard to get something on the books. And then think about different meeting frequency, cadence, agendas for the different groups of folks. Makes a lot of sense. Amanda, anything to add?
Yeah, just on the standing meeting front, like I in teams I work on, we schedule them, but they are not ever the same format. And I actually take this after a long time of being a nurse executive, having to call meetings of folks in a hospital. I refuse to call meetings that are just information dissemination meetings, because I hate to be on those meetings, and I think they're a waste of people's time. So I do like the shared drive for dissemination of information. And so there's places people can go to look up and post how they're doing from their role. So none of our meetings are ever like updates on what's happening. They're always thinking working meetings. So you wouldn't be there unless I expect you to be able to contribute to the meeting. So we put them on people's calendar, but if we don't need to think together about something, then people can use that time to read the dissemination or poke around in the shared drive for what they want or need. But there's not as much like, this is what's going on. I just want to let everybody know in our meetings. And I find that people will then prioritize coming to the meeting when we have them, because they're about thinking and working and I need them there, rather than just being like, okay, I'll put that Zoom meeting on and I'll do something else while I listen to me talk about disseminating everything that's happening. So I've taken that tact like in the virtual world, and it's been easier. I think our meetings, when we have them, are more productive and there's less stuff. And the last thing that I will say that doesn't work is a routine email newsletter. Like, I don't know if any of you have like tried that. I used to think that was a great idea for a big study with lots of sites. People just get annoyed with your study and with you when, at least in my experience, they're not reading it, they're not interacting with it. Nobody wants another email. I think even now more than ever, an email newsletter, while sometimes maybe important, can never be the one way you think you're communicating with folks, because people don't read that. Especially in my world, busy clinicians are never reading those. So I've just basically abandoned that method, even among researchers, and just said, here's a shared drive, information will be there. And when we meet, we're going to talk about important things. So keep yourself up to speed so that you're prepared for the meetings that we're going to have to make you talk out loud in when you come.
Yeah, I think that's a good caution. I think I was just on another meeting earlier today talking about whether to develop a newsletter. And the question was, who's the audience and what's it for? Right. So if you're trying to communicate within a team, a newsletter, at least to me, says this is not personal, right? This is coming from a group. Maybe it's interesting to you, but it's not targeting a specific person. So if you're trying to get to a person, probably having a different method is better. I will also say, as we do work in hospitals and with hospital leadership, I'm exquisitely sensitive to people's time, and that I'm thinking about the projects all the time and they are not. So often what I'll do, no matter how many times I've met with them, is say, just to remind you, here's the objective of the study and here's where we are. Like just a 3-minute level set. And they usually appreciate that. Okay, data hygiene. So implementation research can generate really large volumes of data, qualitative data, quantitative data over different time horizons. How do you manage the data? Where do you put it? Who has access to it? How do you make sure how do you back it up? Like, what are good data hygiene approaches that you would recommend for folks?
I guess.
Yeah, there are many. So I think, I still struggle with how much data to collect. So let's just start with the beginning. Like data, you can get really excited about data, right? Like the what if, and you're talking, anthropologists, right? We do one small sliver of something, we write 700-page ethnography. So this has been a huge learning curve for me, but have a very good sense of why you're collecting the data. And if you don't, save it for another project, because you're going to end up having data that you don't do anything with, and it's basically wasted time. But what we use to save for data depends on the type of data. So for our most increasingly my studies, even if it's an interview-based study, we use REDCap, and that's largely because we use these pragmatic approaches, or we're storing clinical data. So it's just sort of a nice platform where you can keep everything safe. It does take a learning curve to sort of know how to set it up right, but once you do, you have these projects and you can build them and you can link them and you figure it out. So I think in the sort of highest level, we use REDCap and for our data collection. Also, you can do it right. You can add people to it outside of your institution sometimes. So there's some ways in which you can facilitate these large studies. But I think you should very clearly think about who has access to the data and why and at what point. And that's another reason why I like REDCap, because you can sort of limit, you can change who can see it but can't download it. So thinking about why they need the data, and of course, confidentiality and other things. For other types of data, qualitative and other, there are other places where you want to analyze and store it. But this is where something with qualitative, people don't think through it, right? They have their program codes, they're saving their statistical data sets, they have their do files, everything right really nicely. And then qualitative, they're like, I don't know where the interview transcripts were. I don't know what date it was saved. Like, you need to do the same thing for qualitative. You need to set up your folders. Where are you saving them? Have a structure. Where are you going to analyze them? When are you going to destroy them? The same process that you would need as you would for your quantitative. There is not like we recruit through REDCap, but there's not sort of an end all where you can and save it, but that I have at least used.
Yeah, for federally funded research, increasingly there are requirements around managing data. So I think there will be a little bit more structure around it, but it's really helpful to hear from folks what their approaches are. Kate, I 100% agree with you about the need for rigor in managing qualitative data. And also there's this piece of me, maybe it's the belt and suspenders anesthesiologist in me, but we have the raw data files. We keep those separately from the clean data files. We have the original transcript. We have the, de-identified transcript.
Yeah.
Everything's in a different folder. Everything's got its own,
You better have a study ID from the very beginning, because you think you're not going to lose track on those linkage. And then if they're embedded with other trial data, make sure you got that study keys somewhere as well. So yeah.
Absolutely. Yeah. We also have an Excel file with all of our file path locations, so that the structure of the shared drive is on an Excel file. It's a whole thing.
Don't forget. That should be your motto every day. Do not think you're going to remember anything that you did related to data collection and management.
I think one of the biggest challenges is sort of the organization of files and shared spaces. And I don't know, no matter how hard we try to organize them, I feel like just everybody thinks a little bit differently. So like, even if there's somebody super organized who puts together the folders, if you don't like sort of memorize that folder structure and it doesn't make sense in your head, I think that is like that's a challenge that I have never been able to really overcome yet, because it's like we all just think a little bit differently. But I agree with everything everybody has said, and we have a ton of standard operating procedures, including Excel files where we list all of our, data points and what stage in the process they're in. And even like we do a lot of interquarter reliability to establish our code book and things like that. We even include those metrics in there sometimes just to see it, be able to see it all in one place, like how many transcripts, how many interviews have been transcribed, how many have been imported into software, how many have been coded by how many coders. Like you can put it all on an Excel sheet and see it in, at a glance. Because, all our data ends up in qualitative data analysis software like NVivo or, all the others. Those tend to be pretty finicky because they're just huge relational databases that could crash, especially if you're saving them on a virtual space, a shared space, which we always do. So we have really strict rules about how often people save. Everybody, every member of the team has their own folder, and they have an archive folder for backups to make sure we don't lose a lot of work, which has happened, and sometimes that's just the way it works. But, there are all sorts of things you can do to try to avoid that. Yeah, just a lot of things in place to keep track and, protect the data.
Yeah,
One
and you
quick
can
thing
add-
before, oh wait, I
oh,
wanted to
go ahead.
mention for Shimrit, the data, the rules on saving I think are great. It reminds me, I always tell my team, don't save it on your own computer. Like I have to remind people, the shared drive is where the data live. Shouldn't live anywhere else. There shouldn't be anything on your computer. If you get hit by a bus, if I get hit by a bus, we need to make sure everything is on where everybody can get to it. But sorry, Amanda, go ahead.
Oh, I was just gonna, yeah, absolutely. I reinforce that also. And also I have talked a lot with the IT folks around the university. I love RedCap because I've had to go back and recover stuff that folks have deleted. And I know that the server, at least at the School of Nursing has the ability to like go back in time if somebody deletes important information. So I would say wherever you store it, try to understand those parameters and whether you'll be able to retrieve it. And if you can't, then have a place that you first save it where nobody on your team could accidentally corrupt it, et cetera. And maybe only a handful of folks on the team have access to. I learned that lesson the hard way. So yeah, definitely try to save it in a place where they can get it if something bad were to happen.
Yeah. And one other thing is that talk to your data analysts when you are setting up your data collection and management, because and you learn this if you analyze your own data, particularly in RedCap. One small thing that you think won't matter can create 7 hours of work times however many participants down the road for your analysts. So if you aren't somebody that actually, quantitative or qualitative, and this is the same for qualitative, right? Like the way you're saving your data and how you're coding your data really can impact the analysis. So talk with your analysts like, hey, I'm thinking about using a checkbox option. And they're going to say, are you sure? Because how are you going to combine the data when you're done? You better have a good reason for doing that. So things like that may seem like, and they are at the data collection phase, at the data management phase, right? Talk to your analysts. They can help you guide, make sure that data can be analyzed when you're done collecting it.
That's wonderful. I want to come back to something that Kate said earlier about managing access to the data. And that's something that my team talks about a lot. Actually, on our standing agenda is an item called data access. So who has access to the data, who needs to not have access to the data anymore because they've left the team, who's joined the team. And then we also have this sort of minimum necessary privileges concept where if you don't need access to the data, you shouldn't have access to it. If you need to see it but not edit it, we will make it visible to you but not editable. And then there's a much smaller group of people that have editing privileges, but really being mindful of who can do what I think is important. And given this network that we're a part of, the Improved Network, I want to call out some of the concerns that come with data when you're working with Indigenous populations, that we've increasingly become aware that the sovereignty of the data, who own the data, and who have access to the data are especially important when you're working with Indigenous populations. So just another thing to think about, make sure everybody's on the same page about. Great. Well, the last prepared question is about decision tracking. So in the course of implementation research, we change things, right? We might change the intervention a little bit. We might change the implementation strategy a little bit. We might change the study procedures. How do you keep track of those changes? And how do you report them out? But how do you keep track of them?
For changes about the study, decisions that our team talks about that change the trajectory of the study, that's, one sort of living decisions document, and it's dated with the rationale and why do we, just to keep us all on the same page because we're all trying to do lots of things. So that one, it's pretty straightforward, but I think super important because we're always going back to it when we're like, wait a minute, didn't we say we were going to do this? And then we go back to that document. And if it's not documented why, we have a new discussion and we make a decision and we document it. So that from like a research perspective happens a lot. But I'll say in my work, a lot of times it gets dicey when we've planned to do a thing and then we are adapting our thing that we're appropriately adapting our thing to context. And it skirts this line between, is that part of our study or is that just a decision that we made to execute our study? And so we have become more careful in tracking those contextual adaptations separate from, this is just a decision we made to make our study execution goes more smoothly or make a critical decision point, right? So we actually do track those small adaptations. Maybe we thought we were going to give education as a video and we ended up doing it some other way, that's technically science in implementation science, right? Because we had to change the way we plan to deliver a different strategy. And so we track and report those in very different ways and actually make them part of the data for our study. And sometimes classify them as like rescue strategies or different sort of backup strategies, if you will, and we classify them that way if we've had to use them based on data to change our intervention. So kind of two pathways, but the interesting one is really like the actual adaptation stuff, because that's implementation science. And I think a lot of times we don't capture them as data, but we should, because that's helpful to the next person who has to implement whatever it is we're trying to test.
Thank you to Kate for putting the lists paper link in the chat. There are ways to document some of the changes that we make. And so.
And that one has a REDCap project build you can download. I don't get paid by REDCap. It feels like I do. I should contact them. I'll just put on my conflict of interest. But you actually can download a REDCap that does exactly, you can modify it too. It's not perfect, there's clunkiness, but at least it's a start, because I mean, we're just doing this in another working group. Like, people start from scratch. I'm like, don't start from scratch. People have tried to do this. There's no perfect way. There's absolutely no perfect way to track, to Amanda's point, like, this is the science, right? Tracking, that's really important. So we use tools like this, but we also, so like for decision, we have a decision log. Decision logs we use for, like, as we're setting up a trial, right? Or a study or a project, whatever it may be, right? There's critical decisions that have to be made, and I forget them. Again, I forget them. And so we have this log, it has a date, why we decided it, so that when reviewers come back and say, hey, why did you do this? We at least have a decision log. It's also really helpful for analysis to have a decision log. And then, as I mentioned before, the protocol deviation. So if an external thing happens that then you have to change something about your study, often that is sort of in the space of the protocol. We just found out about a copay weird thing that was going on with one of our trials, so we had to shift and change something. So it was an external force, but it was still a decision that we adapted and had to make a change and put it on both of those documents for tracking.
Great. Shimrit, how do you think about tracking these various decisions?
Well, so my strategy of using that living document, that does some tracking on its own, right? Because we save versions and we document things in there as we move along. And I guess we're pretty intentional about it. So like I said, when I talk about having things templated, and I don't use REDCap, but I use Microsoft Access, which does a similar thing. It's a big relational database where you can have forms and you can create forms that collect certain types of information, same idea. And then in there, usually if we're trying to track that, we will have, sort of fields for those things that are happening, just to make sure that they're documented.
Wonderful. Well, that was it for our prepared questions. I do want to say, I want to thank all of our project teams, because it's our project teams that actually help keep us accountable and help us do all of this work. And I'm seeing Casey's avatar up there. She's a project manager that works with me on many things. She's wonderful and keeps me accountable. So thank you, Casey, and all of our teams. We have a question in the chat. So is there one person who's responsible for filling in the decision log, or is it a team effort? Great question. Thank you.
Yeah, so I think it depends on the project for at least our team, but we do have a living document, a living decision log, so people can go in and add it. But in general, we do have sort of a point person on who both tracks regulatory components of a study, and that would include, so anything that would have to be filed, of course, with the IRB, but then there are analysts often are the ones that are tracking the decision log from like a highest level, but it's a joint document in most cases. And I will echo with the project manager, it is a science too. It's not even that they are the only reason that any of this work gets done. There's actually science, and there's papers out there you can read. But the knowledge of program and project management is so substantial. And I think some PIs don't fully, or study leads don't fully recognize how much knowledge is there in science. And so always find an experienced project management lead if you're setting up a study, and just to learn from if you're a new project manager as well.
That's a great point. I will add to that. as much as we think about mentoring for some of our scientific trainees, we should be thinking about mentoring for our staff as well. So whether it's a project manager, research coordinator, whoever it is, think about helping them grow their skill set as well. Because as Kate mentioned, there is a skill set here, and there's knowledge to be learned. Amanda?
Yeah, I would say the project manager is key in the decision log and the tracking of all the decisions. And I will say too, like, so for one of my studies, the project manager I hired had a ton of experience. I learn a lot from her every day, but not a lot in clinical trials, but not a lot in implementation science. So I have invested in them learning more about implementation science so that they can be more of a full partner. And when we make a decision, they're not asking me after the fact, what were you talking about? You know, they know what I'm talking about when I say strategy or adaptation. And so they're just a better partner. So I think that it's been so key to the communication and the continuity and keeping my brain, like probably like everybody else that's here, on track when I'm thinking about a lot of other things and they're just thinking about that project. So project manager or having just a person who's the person to keep everybody on track with timelines, decisions, and sort of things like that, I just think is really important, no matter what that person's role is.
I want to underscore the training piece, because it's really important that all the members of the team understand what you're doing and why you're doing it. And that's something I try to drive home for all the members of my team. No matter what your role is, I want you to be able to explain to someone else, what is this about? What are we up to? What are we doing? What's your role? And the more your team understands what you're doing, the more they understand implementation science, the more they can ask questions that actually make the work better. And so I completely agree with you, Amanda, that you want to think about how to invest in folks so that they can be full participants in the team.
And oftentimes they know just enough, but not everything like everyone else. And they ask these great questions that like the rest of our team would just assume was okay. So yeah, I think it's been a huge return on investment for that, for my team.
They can then anticipate, right? So like not only,
Yes.
right, they see a question or something that's going on and you're, again, not going to be in all the meetings, all the places, and they'll go, wait, that's not quite aligned with, no, that's actually a breach of, fidelity, or, like, so it actually, in addition to their own knowledge and training, it helps you and the study be aligned.
Wonderful. Well, thank you all for your time. We're approaching the top of the hour. It's been an amazing conversation. Thank you for the participants who joined us. Thank you to the Amethyst team, and we hope you all have a great weekend.